issues that are in this transverse plane. So one of the things we will need to know is the foot progression, which we know fits. The other things are the hip rotation and the position of the pelvis. So what did you think of those?
So you can see that we measured increased internal rotation in the left hip, right? Okay, but if you look at hip rotation, it actually looks pretty normal, yeah? So that gray band is normal and the red and green are pretty close to it. But that is because of what is happening at the pelvis, okay? So she has got a net internal foot progression angle, okay? The tibia is in and the femur is in as well, right? Now, you cannot compensate for the tibia, but you can compensate for the femur by protracting the pelvis. So that's what she's doing, so that is retraction, by retracting the pelvis. So she's retracting the left hemipelvis, so that's the left hemipelvis. So she's retracting the left hemipelvis by 20 degrees, which automatically protracts the other side because the two hemipelvis are connected, right? So this is compensation. So mentally what you have to do is negate this compensation. Okay? Push this up, push this down. The minute you push this up, push this down, the left hemipelvis will go into 20 degrees of internal rotation and the right hemipelvis will come into right hip will come into 20 degrees of external rotation. So this is a tertiary level abnormality. And the only way of picking this up is on.
And the other nuance to this is because it becomes obvious that you can go backwards. You can look at the graph and then say, is the graph actually telling me how she's walking? And does it explain why the foot's pointing in that particular direction? And so going forwards and backwards, it's an additional level of information that you can use. The key thing to remember with these graphs is that each one of them is got a particular set of rules behind how that graph is generated. And those rules decide how this information is presented to you. And the person doing the gait analysis and the person reporting the gait analysis must read the same rule book. That's why I said I'm not going to comment on this because these are not graphs that my gait analysis system generates. So I could look at these graphs and be all over the place, but you know them much better than I do. So that's absolutely fair. The other things to remember is that the system has been developed in such a way that it looks for movement in space of particular markers, and it looks at movements of one segment in relation to the other. And you need to know those rules as well. And those rules are that the pelvis rotation is not judged as a pelvic rotation in relation to the trunk. It is judged in relation to the space around the child. So that means if the pelvis turns this way, it is turning backwards in relation to space, and therefore the right side is coming forward, which is why you see them do the opposite in this section here. Second is that the hip rotation and every segment below that at the knee is done in relation to the proximal one. So the knee is done in relation to the hip and the leg is done in relation to the knee. So if one's in, the next one below follows that. But the feet are done again in relation to the lag itself. I don't know why that is. This is just the way they designed it because that's how they found it was most accurate. But that's the rule that we need to know in order to understand this. So some of her compensations are her own, and some of the gait features are because of her bony anatomy. And this is not something that you can get out of physical examination. That's probably the most important point to get here.
So the other thing is how much hip extension you need, okay? And hip extension basically gives you step length. So when I extend the right hip, right, I'm getting left step length. So the more hip extension I get, the greater my contralateral step length. And you saw that her step length was nearly half of normal. And the reason for that is partly because she's not getting knee extension, her knee is persistently flexed, but also because she's not getting contralateral hip extension. So if you correct both of those, then obviously you will improve her step length. So that's what you see. So normally the hip lands at about 40 degrees of flexion, and then in stance it goes The entire stance phase is just characterized by extension of the hip. And then terminal stance free swing, you just lift it up. And that's what you see there. Lands and flexion goes into extension and quickly goes back into flexion again for swing face clearance. Now, the pelvis, this is called tilt, which is this movement. Yeah? Forwards and backwards. That movement. That should be very little movement of the pelvis in that plane. No more than maybe 5 degrees. Right? But in her, you can see that there is a lot of movement of the pelvis. And the reason for that is normally you have pelvifemoral dissociation, which means the pelvis and the femur move independent of one another. And when you have psoas hamstring co-contraction, and muscle co-contraction is very common in cerebral palsy, you have the lack of pelvifemoral dissociation. So the pelvis and the femur move as a single unit. So when the hip goes into extension, the pelvis goes forwards. So that is called a single bump pattern. Okay. So sometimes when you have symmetric spasticity of the psoas or symmetric hip flexion contracture, you get a symmetric double bump. Because on both sides the pelvis is tilting forwards, but in her, the left side is more than the right side. So you get an asymmetric pattern. So that's called a single bump, or it's called an asymmetric double bump pattern. So these are all patterns that you see on weight analysis, which gives you an idea. It's a bit like, on an ECG we would say ST elevation or T-wave inversion. So those are all patterns that we commonly use to denote certain abnormalities. So if there is ST elevation, that means patient is having a heart attack, or that's what I think so, or something like that. So on this double bump pattern, single bump pattern, they're all basically, they mean certain abnormalities. Okay, they are features or videos on graphs that we see.
So to cut to the chase, then how complicated this is. What do you want to do?
So
we asked the audience what they would like to do.
Okay.
So any thoughts, suggestions, options for the girl and the parents?
Extension or lack of hip extension, internal rotation of the left femur and tibia, and I've said that there is a stiffening gait on the left side only. So that's what I've said, and my recommendations are to do a bilateral psoas release, bilateral medial hamstring release, a left femoral and tibial derotation osteotomy, and a left rectus transfer. That was my recommendation. You're free to comment.
I'm free to comment. No, but we can ask the audience if anyone would like to do anything different. Gait features for her, would they change the natural history, do you think?
It's difficult to say.
It's difficult to say, right? And I agree, it's a difficult thing to say. You had a question? Or?
I said there was an incline on the right side also, 10 degree loss.
It was minimal, but it was, I think that's, the difference was quite marked because of the asymmetry. But it was slightly there.
Okay, that's a very good point you made. Okay, that's a great point. It's something I wanted to make myself. Okay, so what Dr. Abhay said was that once abnormalities start with the pelvis, they go down in the same way. Okay, so this girl had severe internal rotation of the left by retracting the left hemipelvis. What happens when you retract the left hemipelvis? The right hemipelvis protracts. Okay? So when you correct the left femur by derotating it, the tertiary level compensation will go, the left hemipelvis will go back to normal, and the right hemipelvis will pull itself out.
Hypotendon was also negative on the right side.
No, it's 30 degrees, it was 30 degrees out. Yeah. On the right side, it was 20 to 30 degrees out. So, the apparent internal rotation you're seeing on the right side is actually the compensation, it's the effect of a tertiary level compensation at the pelvis for severe internal rotation on the left. So, you do not touch the torsional plane problem on the right side because it will go away.
So, my question to you is like, starting with the bony surgery.
Okay.
femoral and tibial derotation osteotomies means 2 bones or 4 bones, depending on whether you do them together or separately, which is again quite tricky. Our preference would be to do the femur and tibia on one side in conjunction, so you adjust one in relation to the other.
She needs it only on one side.
So the most important thing here is the left side is the one where the femur is internal. So there is anteversion of the femur and the foot is possibly following that. So what we would recommend is derotating the femur to where the anteversion is brought down to 15 degrees and then judging where the foot is. So you judge where the foot is, and if the foot then is in a reasonable position, you can leave it there. You don't need to then derotate because that is adding one more level.
Sure.
The second thing is that when you showed us her cognitive angle, it was only about 30 degrees. So she does not have any true hamstring shortening. She has some hamstring spasticity, and that is what's possibly giving you some of this. So I would not do hamstring surgery, I would just give her hamstring Botox.
Okay, and you do the psoas?
So then it comes to deciding what to do at the hip. Now this is the hardest level to correct because what we don't know is how much hip extensor weakness she has. And I would look at that very carefully, and if she had good hip extensor strength, and there was true hamstring, true psoas contracture, then I might do a psoas lengthening. If not, what I would do, rather than try and weaken the psoas as well, is when we were doing the femoral derotation, we would just build in a little bit of extension. So what that essentially is doing is trying to mimic getting that hip extended, but not actually increasing the number of procedures that we would do. I would not do anything for the rectus, because the rehab for a rectus transfer is incredibly tricky because you have to get that transfer moving by getting the knee moving very quickly afterwards. And if you wanted her to recover, then getting her to recover from the bony surgery would be far easier than getting her to recover from the bony plus the rectus.
Okay, but if a rectus transfer was required later, then
you could still, if you would have you recognize why. But I said,
once we had, one professor who made a hazy slide. He said because the indications are hazy.
Hazy, right? Okay. I might do that.
So I would like to ask one question from the audience. How many people felt that 3D gait analysis really contributed something more than what you otherwise had? In terms of because with the previous 2 cases we did not have 3D gait analysis, whereas with the 3rd case we had 3D gait analysis. How many in the audience felt that improved your ability to make accurate decisions? Okay, let's say about 50%. How many people felt that it was useless, it did not help at all? Why not?
Firstly, I want to ask one question. I am parent of that child. If the gait will improve, doing all these soft tissue surgeries and bony surgeries, will she be going from great?
No. It is not about the surgeries. It is about the ability of gait analysis to give you more information. That's all.
My personal opinion is that it is very clumsy. It's very tricky that to chart out all these things.
No. Even neurosurgery is extremely tricky, but that doesn't stop people from doing it. So I'm not asking about how expensive it is or how tricky it is. With gait analysis, did you have more useful information in your hand to be able to make a decision?
It does. But
Thank you.
yes, there are 2 things
So one thing, definitely it gave you more insight into the thing that rotations we were able to assess. But surgical decisions which we made by clinical examination were approximately rather the same.
More or less same.
No. See, that is what. See, without an X-ray, if you have a bend.
I don't think it's a technology.
Absolutely. So you're just using technology to get better.
If you have-
Okay, you will reach. If I had started walking from Bangalore, I would have reached Hyderabad. No doubt about it. So why did I take a flight? Okay, so what you know,
In her case, just as I want to say, in her case, it gave few informations, but ultimate surgical decision, were they affected by the 3D gate analysis?
So it's a question of, it's a very good question. The question is, does the ability to get more information change your clinical decision about what you do? And the answer is never yes or no. The answer is, it gives you a better understanding for why you are doing certain things. It gives you an amount by which you can measure change, and by looking at the outcome through the same physical measure, which is gait analysis, it gives you an understanding of how well you are doing things. So I would say that to try and get gait analysis down to a single yes or no question is missing the point altogether, because if you look at 10 orthopedic surgeons and you show them one femur fracture x-ray and ask them to tell you how they were treated, you'll get 10 different answers. So you don't blame the x-ray as they saying that this is the reason why everyone chose something different, because every surgeon picked a different treatment option based on a series of things that they use to decide what they do. So for us in this area, which is cerebral palsy, because we accept that the condition itself is so complex, we have used this measure as a way of increasing our ability to understand a complex condition. And based on that, we try to improve our decision-making process. And it's not perfect, but it is a step in the right direction. It's not a step in the backward direction by saying, no, it doesn't make any difference at all. Because the answer I have, well, how do you know? You don't have a measure to tell me that your outcomes without gait analysis are better than my outcomes with gait analysis. How can you make that prediction? So I can turn the conversation around the other way and say, you wouldn't go somewhere without GPS if you didn't know where you were going. So how can you blame the GPS? So that's just the other way of looking at it. Would you agree, Jay?
yes. So it is a tool. Okay, gait analysis is only a tool. Okay, who uses that tool? Okay, a knife can be used for good or for bad, and nuclear energy can be used for good or bad. So it's like that. So don't blame the technology as much as how people are employing it and using it, and know its limitations and know its strengths.
So on the basis of this part of the discussion, I would like to hear what